Hello everyone, this is Shadi Reis from Jeddah, SAS's Studio 2024. I'm really privileged today to be with Dr. Ali 𝕊𝕠𝕒𝕡 as well as from Sam Al-Asiri to talk about a phenomenal case just presented at the meeting talking about left main. Dr. 𝕊𝕠𝕒𝕡, thanks for being with us. We'll start with you. So we know the literature now is, we have a lot of studies looking into PCI versus cabbage for left main intervention. What is the current state of the art from your experience?
So we do have randomized clinical trials, and we have also large registry that mostly reflect what is the everyday practice, because we have to keep in mind that the majority of the patients in our practice are not suitable for randomization in clinical trials. And we do have recent meta-analysis by 𝕎𝕑𝕒 that was analyzing and pulling together the data from the major randomized clinical trial. So from that meta-analysis, from the literature that we have so far, PCI is, as it is indicated and recommended in 2018 as guidelines, recommended as a class 1A, as a bypass surgery for isolated left main less than 22, and indeed for less than 32, there is a 1A class of recommendation for indeed cabbage, and 2A for PCI. It's always 1A cabbage. It's standard of care, and PCI is 1A2 when there is an isolated left main with not complex coronary artery disease, and this is testified by symptom score less than 22. Then less than 32 in guidelines nowadays by ESC from 2018, it is indeed an indication 2A for PCI, and then more than 32, it means left main with very complex coronary arteries, and again, this is indicated for cabbage. But this is for patients that are amenable for both type and modality of revascularization. But indeed, in everyday practice, you can have patients that, because of comorbidities, presence of comorbidities, older age, they can be turned down by surgery. So, important, the evidence from randomized clinical trial, but also to keep an eye, which is really the population we are treating in our everyday life.
Excellent summary. So I'll come to you, Salim. How about the role of imaging for left main?
Well, I think the role of imaging is actually mainstay in particularly the left main intervention. The case that was done was, done nicely. They did actually pre-intervention imaging, and they did afterward as well for optimization. In particularly the IFAS is very clearly stated in the guidelines and in the trials, and we do actually have even cutoff for planning for left main. It's in 5.9 MLA less than 5.9, and in Asian population less than 4.5. So it's really the rule is there, and it's emphasis on using it in left main is actually very clear and stated very clearly. And also in optimization, you want to see if you cover the ostium of the LAD and circ very well. Also optimization of the left main and pod technique can be driven also by IFAS finding, and also it can help you even before that in terms of choosing the calcium modification technique, so basically it's very, very important.
And this is one of the highlights of the meeting. And actually, for the last 2023, the majority of 2023, it was a lot of emphasis on imaging and physiology for any PCI, but definitely for left main, it's almost a must for that. So to go back to you, Dr. 𝕊𝕠𝕒𝕡. So sometimes, and we saw some illustration during this conference and others about doing physiology for left main. Is there a side evidence? Is it something FFR, RFR, IFR comparing this modality in left main?
I mean, this is just to guide the intervention in terms of the severity of the lesion and if this is functional significant. But then, if you talk about guidance of the left main intervention, clearly the role is for imaging. The role is for imaging. We have trials now, randomized clinical trials supporting. We have meta-analysis supporting. If you want to do a PCI intervention, especially in a complex left main, which means a distal left main, if you are going to do IVUS, this is going to be impacting on the outcomes. If you don't do IVUS and only angio-driven, the outcome will be worse. And we are not talking about not hard endpoint, but we are talking about stent thrombosis and mortality.
Absolutely, especially in upstream. This
can guide the procedure in the sense that can help to evaluate if an intermediate lesion is significant or not, but then at least that's my personal perspective, a must is imaging. Then it can be IVUS or OCT, we can discuss on that, but this is a must, which does not mean only to put a catheter down, but to be able to interpret the data and really to be sure that the PCI you did is an optimal PCI.
Yeah. I would like just to recap. Go ahead, Dr. Asiri.
Well, I mean, if you're going to use physiology as well, just one thing. I mean, when you engage the guide very close to the lesion and maybe not, that accurate, so maybe pulling the guide to get a proper measurements of the physiology.
Especially at the beginning, normalization can be dampened when you're.
And I see if it's intermediate lesion, combining physiology and imaging and geography is probably the right way. It's two things complement each other.
Absolutely. So I'd like to recap this wonderful discussion. If you have the guideline now is just go straight, CABG is definitely the standard, but if somebody has a low syntax score less than 32, as well as not candidate for surgery, especially if it is not just the left main, PCI is very doable option. IVUS is a must, absolutely, there's no question about that. And again, in terms of techniques, there's too many techniques, too many studies, I think can be covered in a different talk. But I think these are the very strong guide rails for us for left main intervention.
Yeah, but these are guidelines from 2018 by European Society of Cardiology. Let's wait for the new guidelines that are
might change, absolutely, yeah.
This 2023 and see how they are reflecting the evidence from meta-analysis that there is no survival difference between PCI and CABG for lower scale of symptoms.
Absolutely, like mid-shaft or us left main. Well, at the end, I would like to thank you for your time. Really, I enjoyed talking to you. And for our audience, thank you for watching us. This is Shadi Reyes from Jeddah SASS Studio 2024, and I hope to see you next year. Thank you so much.